Portal hypertension is defined as the elevation of the hepatic venous gradient to more than 5 mmHg. Clinically significant portal hypertension is present when this venous pressure gradient is exceeding 10 mmHg, and risk of variceal bleeding increases beyond a gradient of 12 mmHg. Measurement of portal hypertension. Hepatic venous pressure gradient is the difference between the wedged hepatic venous pressure and free hepatic venous pressure. Now, understanding the anatomy of the portal venous system. So, portal vein is formed by the union of superior mesenteric vein and the splenic vein, which is just posterior to the head of the pancreas at the level of second lumbar vertebrae. Understanding its tributaries. The portal vein has ideally two main tributaries, splenic vein, as you can see here in the image, and iliac trunk. Again, it has some minor like coronary vein and pancreaticoduodenal vein. Understanding the etiology of portal hypertension. Causes. Prehepatic causes there is portal vein thrombosis, splenic vein thrombosis, and massive splenomegaly. Understanding the hepatic causes. Hepatic causes is again divided into three types, which will be pre-sinusoidal, sinusoidal, and post-sinusoidal. Post-hepatic causes, it could be Burt's, inferior vena cava obstruction. Cardiac causes may just like arrhythmias, pericarditis, or cardiac failure. Like understanding the sinusoidal causes, cirrhosis of liver. Pre-sinusoidal may be due to schistosomiasis, and post-sinusoidal may be due to occlusive syndrome. Understanding the pathophysiology of the portal venous. Increased portal vascular resistance leads to the gradual reduction of the blood to the liver, allowing portal blood to bypass the liver and enter the systemic circulation. Portal vascular resistance is increased. Understanding in chronic liver diseases. Now what happens? Liver cell injury, which leads to the stellate cell formation, and these stellate cells transforms into myofibroblast, which leads to the contraction of the injured cells and irregular flow pattern in the liver, causing increased resistance and thus ultimately leading to portal hypertension. Now understanding the major collaterals of the portal system. So if we talk about the major collaterals of the portal system, it is 12 in number, as you can see: the coronary, paraesophageal, esophageal, paraumbilical, caput-medusa, perisplenic, retrogastric, gastrorenal shunt, splenorenal shunt, mesenteric, hemorrhoidal, retroperitoneal, paravertebral. Now, understand the clinical features of the portal hypertension. There will be abdominal wall varices, as you can see here in the images. Prominent collateral veins radiating at umbilicus and surrounding areas as caput-medusa. Now, after some important clinical features, this is diagnosis and examination. We will do imaging, ultrasound. We will do some ultrasound, Doppler ultrasonography, CT scan angiography, MR angiography, endoscopy to detect grades of varices. Treatment: hemodynamics of the patient is monitored, frozen plasma, vitamin K, platelet transfusion if needed, and if there is a hypovolemic condition, we will do all this. Tips is very important, which is the transjugular intrahepatic portosystemic stentions, and sclerotherapy is best gold standards, which does not lead to any kind of surgery in case of bleeding veins.